Hello, welcome back everyone, and I hope everyone of you is doing good. Okay, so we're going to do remaining topics of the physiology. Anybody have any question before I start? Everything good? Okay, let's start our lecture. All right, so we're going to do today the acid-base disorders and the renal tubular acidosis. So before doing this, there are some hormones which are being produced by the kidney. So let's quickly discuss that, and there are very simple hormones being there. So simple hormones means your EPO, erythropoietin. So erythropoietin is produced by the kidney. The cells of kidney which produce the EPO, they are called PCT cells, proximal converted cells. So PCT cells, they are going to produce this. So PCT cell, I would say intestinal cells of the PCT or peritubular cells, they produce the EPO. And what they will produce the EPO when there's a hypoxia in the body. Reduced oxygen will lead to increased EPO production. And this EPO is going to do what? It's going to stimulate the RBC, going to stimulate the RBC proliferation in the bone marrow. Okay. All right. So, in which group of the patients we give the artificial EPO? Can anybody tell me? In what disease we have to give the exogenous EPO?
CKD.
Very good. What did you say?
CKD.
CKD, chronic kidney disease patients having the. So, what are the side effects? Can anybody tell me the side effect of exogenous EPO? If I give exogenous EPO, what are the side effects of this? Hmm? Exogenous EPO.
Hypertension
Very good, Rahul. Why? Why it causes hypertension? What's the reason?
because it increases the blood viscosity.
Excellent. Very good. Excellent. Good job. So it's going to increase the blood viscosity. Very good. One is this. And second, what side effect you will see when you the increase viscosity of the blood? So hypertension, it can cause hypertension. Very good. And what else it can cause? It can very important to know. It can increase the risk of the thrombosis, thromboembolisms. Very good, Huzi. Excellent. Your response is late today. Be quick, okay? So thrombosis, quicker than me, okay? So, all right, so thrombosis can be there, and this thrombosis is because of stasis of the blood. Why there's a stasis of blood? Because of the hypercoagulability. Excellent. So now we have another hormone, which is actually, I would say, hormone or vitamin. Vitamin D is there. Vitamin D is actually being produced by what cells? PCT cells are there. Most of the hormones are produced by the PCT cell. PCT cells have one enzyme that is called alpha 1 hydroxylase, which will convert 25 hydroxy vitamin D3 into 125 dihydroxy vitamin D3, which is called calcitriol. It will produce a calcitriol. Can anybody tell me what are the stimulus or what are the factors which will activate the alpha 1 hydroxylase activity?
Parathyroid hormone.
Very good. Everybody remember. Could you please tell me what other factor? Everybody remember that PTH.
Calcium, low calcium.
Yeah, you close. Very good. So can anybody tell me low vitamin D is obviously is a easy way. What are other stimulus? One is PTH when you have the increased PTH, and second is actually decreased phosphate. Okay, when you get decreased phosphate, you need when you have the decreased phosphate, what will happen? It will actually lead to more calcitriol. You need more calcitriol to increase the phosphate. Okay, it makes sense. Okay, so increased PTH, decreased phosphate are the stimulus for the production of calcitriol. Now there's a one disease. Can anybody tell me the name of the disease in which I get lot of the alpha 1 hydroxylase activity?
Sarcoidosis.
Excellent, very good. Any kind of multinucleated giant cells, any kind of the granulomatous disease, non-caseating granulomas or caseating granulomas, they have the multinucleated giant cell. Multinucleated giant cells will have the alpha 1 hydroxylase activity. Okay, now other hormone is called prostaglandins. So prostaglandin is actually produced by the kidney. And what cells of the kidney will produce the prostaglandin? Yep. Who's going to produce the prostaglandin? It's being produced by the cells near the efferent arterioles. Efferent arterioles itself produce your prostaglandin, which is going to do what? Which is going to vasodilate the efferent arterioles. Vasodilate the efferent arterioles. Okay. Vasodilate efferents. Okay. Efferent arterioles. All right. So that will be the paracrine secretions by that. Now, prostaglandin synthesis is going to be decreased by the NSAIDs, and that NSAID has what? NSAID is actually, going to reduce the prostaglandin synthesis, so reduce the renal blood flow. Okay, so dopamine is also there, which is also fourth hormone, which is produced by the PCT cells, dopamine. And what's the role of dopamine in the kidney? Can anybody tell me the role of dopamine in the kidney? Yes?
Vasodilation of the efferent
Well, it is
kidney arteries.
it is going to do so depending upon the dose of the dopamine at low dosage, at low dose, it's going to do what? It's going to vasodilate the efferent arterioles. It's going to vasodilate the efferent and the efferents both. Vasodilate. So if it vasodilate both efferent and the efferent, you will get nitriuresis. It will decrease your blood pressure. At lower doses, dopamine actually decreases your blood pressure. I don't know if you have if you have heard the name called phenol dopam. Phenol dopam is being used to treat the hypertension. That's most often after surgery, post-operative hypertension, because we use a low dose of the dopamine, which will reduce the blood pressure. But when you use a high dose dopamine, when you use high dose dopamine, it's going to do what? It's going to cause vasoconstriction. Can anybody tell me why? Why high dose dopamine causes vasoconstriction? Yep. Low dose dopamine will stimulate the D1 receptors. T1 receptors, which are present in the efferent arterioles and the efferent arterioles. High dose dopamine can also stimulate the alpha 1 receptors. It can stimulate the alpha 1 receptor. So when you get the alpha 1 stimulation, it will lead to vasoconstriction. Okay, so these were the kidney hormones I thought to discuss. Now we discuss the potassium shifts, hypokalemia, and the hyperkalemia. So first we discuss the hypokalemia. So hypokalemia means potassium is going into the cell. In the blood, we have the less potassium being there, hypokalemia. Can anybody tell me what are the causes of hypokalemia? Means potassium keep going inside the cell. Suppose this is my cell and this is my blood. So potassium keep going inside the blood, inside the cell. Inside the cell. Very good. Insulin is there. Excellent. Very good. One cause is insulin. Very good. Potassium goes inside the cell. So shifts potassium into the cell. Very good. So one is actually insulin. Very good. What else? Anyone? Insulin.
Thiazides.
Very good. What did you say?
Thiazides.
Digoxin will increase the potassium. Digoxin blocks the sodium potassium ATPase. So if you block the sodium potassium ATPase, the potassium will remain outside. Is it?
Beta 2 agonist.
Beta agonist, excellent route. Very good. Beta agonist. Do you know how beta agonist cause hypokalemia?
It activates sodium potassium ATPase.
Very good. Excellent. Excellent. Do you know? So somebody, here might be new. Sodium potassium ATPase do what? This is my sodium potassium ATPase pump. This pump sodium potassium ATPase. This do what? This sodium potassium ATPase is actually shifting the 3 sodium outside, moving 3 sodium outside the cell and moving 2 potassium into the cell. So if this pump is actually functioning more, you will get what? Hypokalemia. So beta agonists will do what? They will actually increase the number of sodium potassium ATPase on the surface of the cell. So this will be called your beta agonist. Very good. Very good. What else? Increase the activity of sodium potassium ATPase will lead to hypokalemia. Yep. What else? Very good. Vomiting can cause, vomiting can be there. Very good. Vomiting can be there. Vomiting can be there. So how does the vomiting causes? Vomiting is going to cause hypokalemia by causing alkalosis. Alkalosis. Very good. So alkalosis, can anybody tell me how alkalosis causes the hypokalemia? So remember, on the surface of every cell, we have the pump that is called your proton potassium exchange pump. This is called your H plus potassium exchange pump. And this pump actually, it's going to exchange the H plus with the potassium, and it's a concentration gradient dependent pump. For example, suppose what happens in alkalosis. In alkalosis, what happened to your H plus ions in the blood? H plus ions in the blood will decrease, is it? In alkalosis. So what will happen? This pump will actually function as what? This pump is going to, so H plus ion decreases in the blood. Okay, H plus ions inside the cell, they are more. So this pump will actually function like this. It will actually move the H plus into the blood to neutralize the alkalosis and remove the potassium from the blood into the cell. Okay, so this pump is actually, bidirectional. Sometimes it might move the potassium from the cell into the blood and from the blood into the cell. So depending upon the concentration gradient. So here alkalosis means decrease H plus. So H plus will come out of the cell and the potassium will go into the cell. So this is the reason your alkalosis will always cause what? Hypokalemia. Whereas your acidosis will cause the opposite. I will discuss the acidosis and then ask you. Okay. So this will be there. All right. These are the causes. Now, last cause is called hypoosmolarity. Hypoosmolarity, when you have the less osmolarity is there. Can anybody tell me what's the mechanism? How does the hypoosmolarity causes hypokalemia? Hypoosmolarity means your osmolarity is 260. Normal osmolarity is actually what? Normal osmolarity is actually 290. Can anybody tell me how hypoosmolarity will cause hypokalemia?
Aldosterone stimulation.
Very good, very good, very good. Good job, very good. You're close, but not authentic reason. When you get hyponatremia, when you get hypoosmolarity means hyponatremia. Your sodium is less. Okay? Your sodium is less in the blood. So if your sodium is less in the blood, it will lead to increased activity of sodium potassium ATPase pump. Increased activity of sodium potassium ATPase pump. And when you have the increased activity of sodium potassium ATPase pump, what will happen? You get what? More shifting of sodium outside the cell and the potassium coming into the cell. This is the reason hypoosmolarity will cause what? Hypokalemia. Did you guys understand the causes? Very, very important to know. Did you understand the causes? Alkalosis, beta agonist, hypoosmolarity. Now we are going to discuss the your hyperkalemia, increased potassium in the blood. Potassium in the blood. So opposite, what will be the causes of increased potassium in the blood? Suppose again, this is my cell and this is my blood. This is my blood. So here I have the more potassium in the blood. More potassium in the blood. So what will be the causes of more potassium in the blood? Yep. What pathologies can cause more potassium in the blood? And very important, when you decrease the activity of sodium potassium ATPase pump. Suppose this is my potassium ATPase pump. Blue one is my sodium potassium ATPase pump. And this is being blocked. This is being blocked. So potassium will remain very good. Digoxin is there. Digoxin, very good. What else?
Cell lysis.
Lysis.
Yeah, lysis, excellent. Very good. That's what I want to listen. Tumor lysis syndrome, excellent. Tumor lysis syndrome. You get tumor lysis syndrome, or you get the rhabdomyolysis, rhabdo. Very good. And because why cell lysis cause hyperkalemia? Can anybody tell me the reason?
Because potassium is more inside the cell.
Yep.
When it lysis,
Yeah.
it causes.
There's more potassium inside the cell. Very good. Rhabdomyolysis. There's more potassium inside the cell. Excellent. Very good. And other will be beta blockers, because beta blockers will decrease the function of sodium potassium ATPase. Beta blockers. Yep. What else? Can I say hyperosmolarity?
Yes, sir.
Can anybody tell me the mechanism how hyperosmolarity will cause the hyperkalemia? Yep. How hyperosmolarity will cause hyperkalemia? Because, yes,
ADH secretion.
you guys are giving me the headache. I just discussed the hyperosmolarity. So opposite will happen in the hyperosmolarity. What will happen in the hyperosmolarity? Hyperosmolarity means what? You already have the more sodium in the blood. So if you have the more sodium in the blood, there will be decreased activity of sodium, potassium, ATPase. Simple. Why don't you use your mind? Be smart. Okay? It's the opposite happening here. It's the opposite happening. So you can say insulin deficiency. You can say the neuromuscular junction blocker drugs, succinylcholine. Okay? So these are the common causes of your hyperkalemia. All right. Now, when you get changes in the potassium, suppose when you have the hyperkalemia, when you get hyperkalemia, okay, when you get hyperkalemia, what will be the symptoms of the patient? Remember, changes in the potassium will always affect your heart. So in hyperkalemia, what will be my ECG changes or heart abnormalities I will get? ECG changes.
I say Daddy. I say.
Good.
I say.
Okay.
Shooting
To mute every.
shouting.
Okay. All right. So ECG changes will be what? You might get what? Wide QRS complex. Wider QRS complexes will be there. Wide QRS complexes. QRS is going to be wider. Wider QRS complexes is going to be seen, and the peak T waves will be there. You are going to get what? Arrhythmias and the muscle weakness will be there. Similarly, what will going to happen in the hypokalemia? In the hypokalemia, what you are going to get? You might get what? Flat T waves will be there, muscle cramps, and your arrhythmias can be seen in your hypokalemias. Now we're going to discuss the every electrolyte disturbance and their manifestation. So let's discuss the hyponatremia. And remember, when you get hyponatremia, reduced sodium in the blood. Remember, changes in the sodium will always affect your brain. Your brain is going to be affected. Reduce sodium in the blood. When you get reduced sodium in the blood, what is going to happen to your brain activity? Your brain activity will be increase or decrease? It will be decrease. It will be decrease. Very good. It's going to be decrease. So you are going to get what? You are going to get lethargy. Your coma could be there. Stupor or seizures can be there. Seizures can be there. Once you get more hyponatremia, you get what? Lethargic, coma, stupor, and the seizures can be there. Now, when you get hypernatremia, it will also affect your brain. So it's also going to lead to what? Hypoactivity of brain. Initially, it will lead to increased activity. Patient will be irritable, and later on, you get this coma being there because it is going to cause central pontine myelinolysis, which we will discuss in the neurology. Okay. Now changes in the calcium. When you get the what? Reduced calcium in the body. Reduced calcium in the body, that's called hypocalcemia. Can anybody tell me the causes of hypocalcemia? We already discussed that in the endocrine. Can anybody tell me the causes of hypocalcemia? What are the
Decreased PTH.
very good? Primary hypoparathyroidism, very good. What are the other causes? Decreased.
Deficiency of vitamin D.
Very good, excellent. Deficiency of vitamin D, excellent. And pseudo hypoparathyroidism. Pseudo hypoparathyroidism can be there. CKD. Very good job. Okay. So that will be your causes of hypocalcemia. And when you get hypocalcemia, the typical feature of hypocalcemia will be what? You will get the short-lived muscle contraction. And these short-lived muscle contractions are called what? Tetany. You will get tetany. Okay. Tetany, which is characterized by muscle spasms will be there. That will be short-lived muscle spasm will be there. So tetany is going to be there. and you might get the seizures. And what EKG changes you will get in the hypocalcemia? Yes, when you get decrease, we already discussed in the cardiology. That's just a brief review. I was thinking to skip this topic. Go to
Prolonged
Prolongation.
interval.
yes, what do you get?
Prolonged QT interval.
Prolonged QT interval, that will be torsade. Very good. Increased QT intervals. QT interval will be prolonged, and that will lead to torsade. Okay. Torsade will be seen. All right. So this will be the ECG, and you will get two signs. One is called your Chustok sign and the Trousseau sign. Can anybody define the Chustok sign for me?
When you tap the cheek of the face, it'll twitch.
Yes. So you get the twitching of the facial muscle, or you get the contraction of masseter muscle by tapping the facial nerve. Okay, and the Trousseau sign is there. And after that, we have the hypercalcemia, and hypercalcemia is simple. You get hypercalcemia secondary to the hyperparathyroidism. When you get hyperparathyroidism, it will lead to hypercalcemia being there. That will be primary hyperparathyroidism, secondary or tertiary being there. So you get increased calcium. So increased calcium is going to kidney stones. So you get the flank pain. Increased calcium can give you the acute pancreatitis, which will lead to the abdominal pain. And you might get what constipation and the neuropsychiatric symptoms. Polydipsia can be there, polyuria can be there because of hypercalcemia. Okay. Now let's discuss the phosphate. What are the causes of hypophosphatemia? Reduced phosphate in the blood. Hypophosphatemia. Yep.
Hyperparathyroidism.
Tumor lysis syndrome.
Excellent. Very good. Tumor lysis syndrome. Excellent. Good job. Good job. Hyperparathyroidism. When you get what? Bone loss will be there. Osteomalacia, vitamin D deficiency, rickets can be there. That will lead to your hypophosphatemia. And what are the causes of hyperphosphatemia? Increased phosphate. Increased phosphate in the blood.
Hypoparathyroidism.
Hypoparathyroidism, very good. Hypoparathyroidism, yes. What else? CKD, chronic kidney disease, CKD, yes, CKD. So when you get hyperphosphatemia, what will the patient's presentation? Patient might get what? Hypocalcemia, because all the phosphate will bind with the calcium. And secondly, patient is going to get renal stones. Can anybody tell me the two stones which are actually composed of the phosphate? We will discuss the renal stone and the pathology. What are the two stones which are that's called calcium phosphate stone and ammonium magnesium phosphate stone? That's called Stegon calculus. Okay. So renal stones can be there, and you might get metastatic calcification, where you get the widespread deposition of calcium in the normal tissues. Okay. So that's all about your phosphatemias and hyperphosphatemias. All right. Now we're going to discuss the features of disorders. I mean, they are very simple. So I'm going to quickly go through that features of renal disorders. So what is going to happen to your urine and the serum when you get this disorders like your. So let me discuss first your Bartter syndrome. So in the Bartter syndrome, we have the defective reabsorption at the thick ascending loop of the Henle. Bartter syndrome, thick ascending loop of the Henle. So there's no reabsorption of what? There's no reabsorption of your sodium, potassium, and the chloride. So what is going to happen to your plasma renin? Your renin level will be what in the Bartter syndrome? Increase or decrease?
Increased.
Increase. Think about Bartter, think about your furosemide. Think about furosemide. And what's going to happen to the aldo?
Increased.
Aldo is going to be increased. Very good. Aldo is going to be increased. So these will be the changes you will get in the Bartter syndrome. And what will happen to the urine calcium? Barter, think about the furosemide, loop diuretic. So what is going to happen to your calcium? Urine calcium?
Increase.
Increase.
Very good, increase, because loop loses calcium. Excellent. Okay. Now coming to your Gittelsman. Gittelsman's is actually defect in the DCT. Think about thiazide, like thiazide. DCT is actually defective. So Gittleman syndrome, you get what? Your renin will be increased, your aldo will be increased because they are all potassium wasting diuretics. And what will happen to your urine calcium here?
Decreases.
Decrease.
Decrease. Decrease. Very good. Urine calcium is going to be decreased. And what is going to happen to your serum magnesium?
Decrease.
Very good. Why? Yeah. Because for the reabsorption of magnesium, you need a reabsorption of sodium and the chloride first. So this pump is not functioning, so your serum magnesium is going to be decreased. Okay. Now coming to the very important one, this is called Little syndrome. Little syndrome and the syndrome of apparent mineralocorticoid excess. Little syndrome. So you guys have to tell me the parameters of Little syndrome, and I'm not repeating the Little syndrome for you guys. Okay, Little syndrome. And this Little syndrome is going to do what? Little syndrome, what will happen to my renin level in the littles? Renin.
Decreased
Why?
because it's potassium sparing.
Because it's potassium sparing.
I think.
Potassium. What is Little syndrome?
It is the sodium channels, the epithelial sodium channels
So
that are.
what
So it's a gain of function, gain of mutation.
gain of function? Very good. So gain of function is there. So you get more activity of the sodium channels. So when you have the more activity of sodium channels, what is going to happen? You get more reabsorption of sodium. So if you have the more reabsorption of sodium, means more sodium chloride delivery to your macula densa. So your renin will be decreased. Very simple. Very simple. I keep repeating from 2 or 3 days, I keep repeating these syndromes. Okay. So what is going to happen to the aldo? Aldo will be obviously low. And what will be their blood pressure?
High.
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 Because of the
More sodium.
more sodium. Excellent. Excellent. Good job. All right. So these were all the disorders. Now we discuss the acid-base physiology, which is actually our topic. And then we discuss the renal tubular acidosis. So let's discuss acid-base physiology. Acid-base disorder. So acid-base disorders, physiology. So, in order to understand the acid-base physiology, first you should understand what is a normal pH. Can anybody tell me the normal pH? What's a normal pH for me?
7.35 to 7.45.
7.4.
Yeah, someone was actually correct. This is actually between the 7.35 to 7.45. 45. If your pH is actually less than 7.35, if your pH is less than 7.35, it will be called acidosis. And I will further discuss the acidosis for you guys. It will be called acidosis. And if your pH is greater than 7.45, that will be called alkalosis. Okay, so this is the one criteria to make the diagnosis of alkalosis. So you have to first look at the pH. If your pH is less than 7.35, acidosis. If your pH is greater than 7.45, alkalosis. Now we have to check. So after this will be our first step to diagnose the acid-base disorder. And after diagnosing this, we have to identify, is it the respiratory acidosis or your metabolic acidosis. So first I discuss the acidosis. I'm going to discuss the acidosis. So acidosis is of the two types. It's actually metabolic acidosis and your respiratory acidosis. So before actually understanding these two types, first I want to mention the two parameters. There's one is called carbon dioxide level. So remember, carbon dioxide is actually equals to acid. It's an acid in our body. Acid. Normal level of carbon dioxide is actually called 40 mm. It's actually 40 mm of the mercury. So 40 is a normal carbon dioxide level. Now, second parameter or second ion which we are going to measure in the blood is called bicarbonate. Bicarb ions. So bicarbonate is actually what? Bicarbonate is acid or alkali?
Alkali.
Is alkali. Excellent. Alkali. And this alkali is normally, is a normal concentration is 24. Normal concentration 24. If you get changes in this bicarb ion, remember changes in the bicarb ion is always metabolic. Primary. I'm talking about primary, okay? Not compensation. It's actually primary metabolic changes. Metabolic. This will be called metabolic acidosis or alkalosis. Now, primary changes in the carbon dioxide level will be always respiratory. Okay? Not compensation, I'm talking about the primary changes. Okay? So changes in the carbon dioxide, if you want to diagnose respiratory causes of acid-base disorder, you have to look at the carbon dioxide level. If you want to diagnose the metabolic causes of the acid-base disorder, you should focus on the bicarb. So this is your rule. Now I'm going to discuss the types here for you guys. So first, let's discuss the metabolic acidosis. Metabolic acidosis. So metabolic acidosis means your pH will be what? Your pH is going to be less than, your pH is going to be less than 7.35. And my bicarbonate ions will be what? So here I have to look at the bicarb ion because bicarb ion is a primary change. So bicarbonate ion is going to be less than 24. Is it? No need to remember the calculation, how much will be the carbon dioxide, how much will be the just general criteria. Bicarb ion is going to be less than 24. So look at this, it is making sense. It is making sense, so it will be metabolic acidosis. So pH less than 3.5, bicarbonate ion less than 24. Now, can anybody tell me what will be my carbon dioxide level? It will be greater than 40 or less than 40?
Should be less than.
Less than 40.
I told you it is metabolic.
Greater
Want to diagnose metabolic, always focus on the bicarb. Do not focus on the carbon dioxide. But if they give you carbon dioxide, that will be greater than, that will be what? That will be less than 40. Why it will be less than 40?
Compensatory mechanism.
Very good. Compensation. So
Ye
this
ye 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 ye. Don't hear Brella.
this no.
Mosiare.
Give me a minute, please. I will be back. Okay? Give me a minute. I don't know who's Hill. Why don't you keep yourself mute, please? Okay, please keep yourself mute. And I'm actually, you know, trying to mute you, but you're again, okay, it's fine. Okay, so we were discussing the metabolic acidosis. So metabolic acidosis, your pH is going to be less than 3.5. Your bicarb will be less than 24 because it's a metabolic one. So you get the changes in the bicarb. And what is going to happen to the pCa2, carbon dioxide level will be less than 40 because when you have the more acid in the body, your respiratory system is going to compensate. For metabolic one, there should be compensation. So if you need a compensation for metabolic acidosis, you will what? You will get respiratory alkalosis as a compensation. So when you decrease the carbon dioxide, it means respiratory alkalosis. So this is actually compensation. Okay, we are trying to compensate. And remember, respiratory compensation is very quick. So metabolic acidosis will lead to hyperventilation. It will lead to hyperventilation because you start removing the carbon dioxide from the body. Now, what are the causes of metabolic acidosis? You will get metabolic acidosis when you actually lose the bicarb ion or you gain the H plus ion. You gain the H plus ion. Gain the H plus ion. Okay. So the causes of metabolic acidosis are divided into two types depending upon the anion gap. So we calculate the anion gap and then classify the metabolic acidosis in two types: elevated anion gap metabolic acidosis, non-elevated anion gap metabolic acidosis, or normal anion gap. So how do we calculate the anion gap? We calculate the anion gap by sodium minus chloride plus bicarb. Plus bicarb. So this is how I calculate the anion gap. So what is my normal anion gap? My normal anion gap should be between 8 to 12. It should be between 8 to 12, and we are going to calculate this here. So you know what is normal sodium? It should be 140. And what is your normal chloride? 105? Is it? And what is your normal bicarb? 24. Is it? 24 is there. So how much it will be? It will be equals to 129. So it will be 11, which is actually normal. Is it? So this is how I calculate the anion gap. So normal anion gap acidosis and elevated anion gap acidosis. Elevated means it is actually greater than 12. So first we will discuss the causes of your normal anion gap acidosis. So what are the causes of normal anion gap acidosis? Can anybody tell me the causes? Normal anion gap. Normal.
Diarrhea.
Very good. Excellent. Why
Addison disease.
diarrhea?
Because we are losing bicarbonate ion.
Very good. Excellent. 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 You're losing bicarb. Very good. Diarrhea. Hyperalimentation. Very good. And somebody says Edinson disease. Very good. How Edinson disease? This is very interesting topic. Very good. Edinson disease. Yep. What is Edinson disease? Edinson disease is what?
Type of adrenal insufficiency.
You get what? Deficiency of aldo. You don't have the aldo. Deficiency of aldo. And when you have the deficiency of aldo, what will happen? You will get metabolic acidosis because you start gaining the H plus ions. You don't lose the H plus ion. Okay. You guys know that aldosterone do what? Normally aldosterone do what? At the kidney, at the collecting ducts, it reabsorbs the sodium and loses the H plus. So in Addison disease, you gain the H plus ion. Okay. So deficiency of aldo. Very good. What other causes which can lead to your normal anion gap acidosis?
Saline infusion.
Saline infusions. Excellent. Very good. Saline, where you give sodium chloride. How does saline infusion will cause? Anybody tell me the mechanism? Saline infusions. How?
Saline contains more content of chloride. To balance that, we are losing bicarbonate ion.
Very good. That's the one mechanism. Excellent. And saline also give you more sodium. Is it?
Yeah.
If it gives you more sodium, it will decrease the aldosterone. So when you have the decreased aldosterone, you are going to get what? Metabolic acidosis. Very good. Excellent. What else? No. Don't make this mistake, please. Okay. Okay.
Renal tubular acidosis.
Renal tubular acidosis. Very good. What type? Every type, type 1, type 2, type 3. We are going to discuss that today. RTA. Very good. Renal tubular
Type,
acidosis. Yeah.
Type 1.
Type
type
1.
2.
Type 1 is actually due to what? Type 1 is actually due to what? Type
Due to the decreased secretion of the H plus.
Excellent, excellent. That's called distal convoluted cells are affected. So renal tubular acidosis type 1 and the type 2 both. Because in type 2, type 1, you do not secrete the H plus. In the type 2, you do not reabsorb the bicarb. Okay. All right. So you can get acidosis by gain in the H plus ion or loss in the bicarbonate ion. Okay. So that should be your thought process. Your thought process should be gain in the H plus ion or loss in the bicarb ion. Very good. Renal tubular acidosis. Excellent. Very good. And last will be spironolactone because spironolactone will blocks the aldosterone. So if you block the aldosterone, you don't lose the H plus ion. Okay. All right. And there's a one diuretic which blocks the bicarbonate reabsorption in the PCT cell by inhibiting the carbonic anhydrase. Can anybody tell me the name of that?
Acetazolamide.
Acetazolamide. Now you get elevated anion gap acidosis. Increase anion gap. Increase anion acidosis. Okay, increased anion gap acidosis means your anion gap is actually elevated. You get greater than 12. So here, the mnemonic is called mud pills. Mud pills is a mnemonic. So mud pills, mud pills. Can anybody tell me what are the causes in the mud pills?
Methanol.
Methanol,
Very good. Methanol,
uremia,
uremia.
Diabetic ketoacidosis.
diabetic
Very good.
acidosis,
Very good. Very good. What else? P, P stand for what?
polyglycol.
P stand for what? Yes. P stand for what?
Polyglycol glycol or something.
Propylene glycol. Excellent. And very good. I stand for
Lactic acidosis. Lactic
I.
acidosis.
Before iPhone, before P.
Iron.
Iron. Excellent. Very good. And L stand for what?
Lactic acidosis.
Lactic acidosis. Very good. Lactic acidosis is there. And S stand for what? E for what? We have the E, ethylene glycol. S stand for what?
Starvation.
Starvation.
Salicylate.
Very good.
Salicylates.
Very good. Starvation, salicylates. So salicylates, early toxicity or late toxicity?
Delay.
Late. Early is always respiratory. Okay, we are going to discuss this. So these are called your metabolic acidosis causes. So metabolic acidosis, what will be you get? I already told you pH less than 7.35, bicarb less than 24, and the carbon dioxide will be less than 40. Okay, so that will be the metabolic acidosis for you. Now let's discuss respiratory acidosis. So respiratory acidosis, if you want to understand the respiratory acidosis, first try to understand the causes of respiratory acidosis. Respiratory acidosis means you are getting retention of the carbon dioxide. Carbon dioxide is getting retained in the lungs. So any pathology which leads to retention of carbon dioxide in the lungs will cause respiratory acidosis. So can anybody tell me what are the causes of respiratory acidosis? You get
Opioid use.
opiates, very good, which will actually slow down your ventilation. Opiates. Very good. What else?
Lung disease.
Uh-huh. Respiratory acidosis. Opiates, you told me because it will actually do what? It will actually slow down the diaphragm. So any pathology which cause hypoventilation, obstruction, very good. Foreign body.
COPD, asthma.
Foreign body, excellent. Very good. COPD.
Weakness of respiratory muscles.
Very good. What are the causes?
Like
What are the causes?
Guillain-Barré.
Myasthenia gravis.
Myasthenia gravis, Guillain-Barré, very good. And you get what? Asthma can be there, very good. So these are the causes where you get respiratory acidosis. So when you get respiratory acidosis, your pH will be what? pH is going to be less than 7.35. What will be my carbon dioxide?
Increase.
Increase.
Please, to diagnose the respiratory causes, focus on the carbon dioxide. To diagnose the metabolic causes, focus on your bicarbonate. So it will be greater than 40. Okay, and what will happen to the bicarb?
It will
Compensate.
increase to
Increase.
compensate it.
It will increase it very good as a compensation. As a compensation, your bicarb is going to go up. It will be greater than 24. Okay, it will be great because it is going to take more time. It will actually take 72 hours or 96 hours to go up because your metabolic process is very slow. It will take more time. So that's called your metabolic acidosis. Very simple causes were there. Now we discuss the respiratory or your alkalosis. So let's discuss the alkalosis. Alkalosis. Alkalosis means your pH will be greater than 7.45. So first you look at the pH. Now the other question you will ask from yourself is what? Either it is due to metabolic or respiratory. So let's discuss first respiratory cause. So remember, if you want to diagnose the respiratory, you will always focus on the carbon dioxide level. So what will happen to my carbon dioxide level in the respiratory alkalosis?
It'll be leaving.
Decrease.
It will be
Less than
less than 40 because carbon dioxide is an acid. In alkalosis, you start losing the acid. So carbon dioxide is going to be less than 40. So what are the causes of this decreased carbon dioxide? Any pathology which decrease carbon dioxide in the blood, in the lungs will lead to respiratory alkalosis. So what are the pathologies? What are the causes? Very simple. What are the causes?
Panic attack from
Anxiety.
hyperventilation.
Yeah.
From
One by one.
Anxiety,
Please, one by one.
anxiety,
Any disease which cause hyperventilation. Very good. Anxiety and the panic attack. Excellent. Anxiety and the panic.
high altitude.
High altitude. Excellent. High altitude. Very good. What else? Yes.
early salad poisoning.
Pregnancy. 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 Very good. Pulmonary embolism. You get tachypnea. Very good. Pulmonary embolism. Very good. What else? What else?
Early
Salicylate.
salicylate acute toxicity, like the delay was
You
we
please,
study
you
over there.
please
This
tell
is
me the mechanism, please. Mechanism, please. How I spread.
Stimulate the medullary center of the brain.
Excellent, excellent. It actually do what? It's going to activate the medullary center. It's going to activate the medullary center to increase the respiration. So this is the cause of. So early you will get what? Respiratory alkalosis. Later on you will get what? Metabolic acidosis. Can anybody tell me how aspirin cause metabolic acidosis? I didn't discuss
Uh,
here because I want to discuss this here.
It inhibits oxidative phosphorylation
Very
and
good. Excellent.
anaerobic glycolysis, so
Very
causes lactic acid production.
Very good. It actually inhibit oxidative phosphorylation. It will inhibit the electron transport chain. Electron transport chain will be inhibited. So you get what? Inhibition of your. Very good. Good job. Okay. So that will be your salicylates being there and high altitude. These are causes of respiratory alkalosis. So respiratory is always simple. It's always simple. Now we discuss the metabolic.
Could you please repeat what happens with when it decouples that cycle?
Sorry, what did you say?
What's happening? I didn't catch the last part when you were saying that it decouples that phosphorylation, and then what happens next?
Okay, okay, yeah, sure. So what's going to happen if you remember from the biochemistry? So when your pyruvate is produced, pyruvate is an end product of glycolysis. Is it? It's the end product of glycolysis, and the pyruvate will go into the Krebs cycle. Is it TCA cycle? Okay. And from the TCA cycle, what will happen? TCA cycle will generate the NADPH. TCA cycle is going to generate what? NADH and FADH. FADH2. And these FADH2, NADH2, they will go where? They will go inside the mitochondrial membrane where electron transport chain is located. Electron transport chain is located. And you know, in the electron transport chain, we have the complexes being present. electron transport chain. So electron transport chain contain the four complexes: complex 1, complex 2, complex 3, and the complex 4. And you know, these complexes will receive what? These complexes will receive the electrons, and when the electrons move through these complexes, the energy is produced, and that energy is used to produce the ATP. That energy is used to produce the ATP. Now, what will happen? Your aspirin is going to block the electron transport chain, aspirin. Aspirin is going to inhibit the complex 4, and when it inhibits the complex 4, what is going to happen? You get what? Inhibition of the electron transport chain, aspirin. And if you get inhibition of electron transport chain, what will happen? Your NADPH level will increase, and if your NADPH level will increase, it will go in the retrograde direction. It will inhibit the TCA cycle, and if you inhibit the TCA cycle, the pyruvate cannot enter into the TCA cycle because there's a blockage below the TCA cycle. Below the TCA cycle, I would say there's a lot of traffic being there. In a simple words, a lot of traffic is there, which is actually blocking the passage of the substances. So TCA cycle is blocked. As a result, your pyruvate will accumulate. And where will this pyruvate go? This pyruvate will actually go into anaerobic glycolysis. So it will be converted into lactic acid. It will be converted into lactic acid by the name of the enzyme that's called lactate dehydrogenase. And this lactic acid will produce the ATP for the cell. So because of the accumulation of pyruvate, you get the production of lactic acid. And you know what is lactic acid? Lactic acid is an acid. When it is accumulated, it is going to give you elevated anion cap. Did you understand that now?
Yeah, it's quite better now. Thank you for clarifying.
Anytime, anytime. Okay. Okay, so this will be your, okay, so this is how the aspirin works. Now let's discuss our metabolic alkalosis. Metabolic alkalosis. So in the metabolic alkalosis, I told you metabolic means bicarbonate. Always think about the bicarbonate, metabolic alkalosis. So, very good. So metabolic alkalosis, so first always pH. First you have to always look at the pH. pH. Your pH will be greater than 7.45, and your bicarb is going to be elevated here. Bicarb is how much? So bicarb will be always greater than 24. Some people say 28, but 24 is actually okay. And 24, because you are actually, the pathology is within the bicarb. You are gaining the bicarb ions. Okay. So what is going to happen to my carbon dioxide level? It's going to be increased, and the reason is that your compensation. You need respiratory acidosis as a compensation. So carbon dioxide is going to be greater than 40. It's going to be greater than 40. So these will be the parameters in the metabolic alkalosis. Now, what are the causes of the metabolic alkalosis? Cause of metabolic alkalosis will be what? It could be due to the gain in the bicarb ion or loss of the H plus ion. You have to think like this. So you have to, think like this. Either I'm gaining the H plus ion or losing the H plus, or either I'm losing the H plus ion or gaining the bicarb ion. Sorry, okay. So what are the causes? Yep. Hmm. Vomiting, excellent. Vomiting, very good. Vomiting, yes. In the vomiting, you lose the H plus. You lose the H plus. Very good. HCl is actually lost in the vomiting. Very good. Loss of H plus. Yes. What else?
Antacid.
Hypovolemia.
Mm-hmm. Vomiting. Very good. Yes. Think about the more effect of aldosterone. If I have the more aldosterone, what will happen? PPI is, how will PPI cause it? PPI will increase it, PPI is going to decrease the H plus in the stomach. It doesn't decrease the H plus in the blood. So vomiting is there, which actually, no diarrhea, no. Your concept needs to be clear. I think their concept is not clear. So look at this, metabolic alkalosis can be because of two reasons. Because of two reasons you will get metabolic alkalosis. One reason is what? One reason is actually you have the increased bicarb. Increased bicarb, or it is called the gain of bicarb. You are gaining the bicarb. And second reason is what? You have the decreased H plus. This could be due to the loss of H plus. So tell me the situation in which you lose the H plus. So one disease you told me was a loss of H plus is vomiting. Okay, if you don't anticipate, you will forget after the class. Why I'm wasting more time here? Because I want to clear the concepts. So this, if you just keep this thought in your mind, your gain of the bicarb or loss of the H plus, that's going to help you. Yep.
Aldosterone, increase aldosterone.
Very good. Increase aldosterone. When you have the increased aldosterone, which it will do what? It will actually start losing the H plus in the urine. Very good. Increase aldo. So what are the diseases in which you get lot of the aldosterone?
Barrett syndrome, Gitelman syndrome.
Very good. Excellent. That's what.
Sex Fanconi.
Hyperaldosteronism.
Hypovolemia, losing
All,
volume.
all potassium wasting diuretics. All potassium wasting diuretics. All potassium wasting diuretics. Okay, your thiazide, your loop diuretics, Bartter syndrome, Gittleman syndrome. They're very easy to know. They're very easy to know. Okay, so all potassium wasting diet, increase aldosterone. If you want to understand the metabolic alkalosis, increase aldosterone. And increase aldosterone. What are the diseases or what are the drugs which increase aldosterone effect? We already discussed that. Now, antacids can PPI, not PPI, but antacids. Antacids like your aluminum hydroxide, magnesium hydroxide, they can actually cause metabolic alkalosis. Okay, antacids, because they contain the bicarb ion. That is the reason we give the antacid. PPI, in the options I think I saw only PPIs. I didn't give a focus on the antacids. Your antacids can cause the alkalosis because that's the role of antacids. Antacids do what? Okay, I'm sorry, Aisha, if I didn't saw the antacids. Okay, I didn't give more focus. So antacids are
No, it's okay.
okay, thank you. Thank you for understanding. Okay, so antacids are going to do what? Antacids will actually increase your, I would say, the bicarb ions. So that's the reason they are actually causing the metabolic alkalosis. Okay, so metabolic alkalosis are very simple causes and is very easy. Did you guys understand these acid-base disorders? Very simple. Get it? Anybody have any question? All good? Okay. You guys have a UWorld class today? Do you guys have UWorld class? Or we can continue. We can continue and complete this. Give me a minute. We will continue. We are here. We are going to complete the physiology today. Okay. This will take more time. Okay. I will be back. Hello, hello. Hi. Okay, sorry, I'm taking more breaks today. I'm sorry for any inconvenience. So let's discuss the renal tubular acidosis, RTA, renal tubular acidosis. So you are getting acidosis secondary to the defect in the renal tubules. That's a definition of renal tubular acidosis. So there are multiple areas where you can get this defect because you can have the defect in the distal convoluted tubules, proximal convoluted tubules, or collecting ducts. So renal tubular acidosis. So there are three different types of renal tubular acidosis depending upon the location of the tubules being involved. So first we are going to discuss distal renal tubular acidosis. As the name suggests, distal. So you get what distal. So very easy. These disorders are very easy to understand. Distal renal tubular acidosis. So as the name suggests, distal, and it is also called type 1 acidosis. Type 1. It's called your type 1, RTA type 1. Simply, it's called RTA type 1. Now, as the name suggests, distal, so it means the pathology will be where? The pathology is going to be in your collecting ducts. It's going to be in the collecting ducts. So, in the collecting ducts, we do have one cells that's called alpha intercollected cells, which we discuss in the physiology. Alpha intercollected cells. Can anybody tell me the role of alpha intercollected cells? So this distal renal tubular acidosis is due to the defect in the function of alpha intercollected cells. Alpha intercollected cells are not functioning properly. Alpha intercollected. Alpha intercollected cells have what? Decreased function. Decreased function, and that function is what? They are unable to secrete the H plus ions into the urine. So alpha intercollected cells cannot secrete H plus ion in the urine. Cannot secrete H plus ion in the urine. In the urine. Okay. Normally alpha intercollected cells secrete the H plus ions in the urine. So as a result, what will happen? You will have the retention of H plus ions in the blood. Retention of H plus ion in the blood. And when you retain the H plus ions in the blood, what will happen? When you retain the H plus ion in the blood,
Metabolic acidosis.
you get acidosis. And that acidosis will be called metabolic acidosis. That acidosis is called metabolic acidosis. So your H plus ions in the urine will be decreased and the blood it will be increased. So what will be my urine pH?
Increase.
Very good. It will be greater than 5.5. What's the normal pH of the urine? 5 to 5.5. And here it's going to be decrease. It will be increased. Sorry, it will be greater than 5.5. Okay. Greater than 5.5 urine pH. Okay. That will be your distal renal tubular acidosis. Now, what are the causes of distal tubular acidosis? What are the causes of distal renal tubular acidosis? Anyone? What are the causes which will actually decrease the function of distal renal tubular cells or your alpha intercollected cells? This could be due to what?
Some drugs like analgesics, they damage this.
Excellent. Some drugs like
Alpha
it's like your amphotericin B, which is very common. Amphotericin B, ampho B, ampho B, very good. Ampho B. What else? Could be
autoimmune diseases.
autoimmune, very good. Lupus nephritis, very good. Lupus nephritis. But very important to know when you get what? Posterior urethral valve. When you get obstruction in the urethra or bladder. Can anybody tell me how obstruction will cause RTA type 1? Obstruction. And that obstruction we most commonly see is what? Posterior urethral valve. Posterior urethral valve will be there, and that will lead to bilateral hydronephrosis. Obstruction. Obstruction will lead to what? It will lead to ischemic injury or pressure injury to the alpha intercollected cells. So drugs, congenital diseases, autoimmune diseases, they are the causes of your renal tubular acidosis. So how the patient is going to present? What will be the typical presentation of the patient? Symptoms. These patients are at the risk to get what? Kidney stones. Can these patients get kidney stones? They can get
Yes.
kidney stones,
Yes.
and these will be kidney stones. They will be precipitating at the alkaline pH because your urine is getting alkaline. So, what kidney stones are formed? There are only two kidney stones which are formed at the alkaline pH. Rest of all are at the acidic pH. It's too wide. Very good. That
Alkaline.
will be Stagon calculi. Very good. Magnesium, ammonium, phosphate kidney stones. Very good. Another is called calcium phosphate stone. These patients are at the risk to get calcium phosphate stones. Okay, calcium phosphate stones will be seen. Okay, because of the and why we get the calcium phosphate stone? Because of two reasons. One reason is actually you get the increased pH of the urine, and second reason is what? Second reason is actually you get increased bone breakdown. Why do you get the increased bone breakdown? Can anybody tell me what's the reason? Why do we get increased bone breakdown?
Because of acidosis.
Why acidosis increase the bone breakdown?
Acidosis will lead to bone resorption of calcium.
Why? Why? I told you medicine without evidence is tasteless.
There was some buffering mechanism.
Yeah, what is buffering? What is buffering? Because remember, osteoclast activity is very high in the acidic bone environment. When you when you have the acidic bone environment, when inside the bone, when you have the more H plus ions, it is going to do what? It is going to increase osteoclast activity. And I think I didn't do a MSK with you guys. I did a MSK with the my batch. So when you have the more osteoclast, when you have the more H plus, more osteoclast activity. And osteoblastic activity is very high at the alkaline pH. And do you know,
Osteopetrosis.
yeah, that is why the indicator of increased osteoblastic activity is what? Increased alkaline phosphatase. When you have the more ALP, being the alkaline phosphatase is there, when you get more ALP in the blood, it is due to what? It's due to increased osteoblastic activity. Okay, so this is very important to understand. This is the reason you get increased bone turnover, and if you get increased bone turnover, you get increased release of phosphate and the calcium. So when they go into the urine, in the urine they get an ideal environment to precipitate as a calcium phosphate stones. So renal tubular acidosis type 1 increase the risk of calcium phosphate stone. Okay, so did you guys understand renal tubular type 1? Any question, any confusion?
Yes.
Now what will be my serum potassium in these patients?
Decreases.
Why?
H plus potassium ATPase pump is inhibited.
You get acidosis. So you get acidosis means you have the more H plus ions. So more H plus ions, so your H plus will go into the cell and the potassium will go what? Out of the cell.
Out of
Increase it. It should increase it. Why it is decreased? Hmm? If you actually follow that pump, it should increase. Is it? The reason is that alpha intercollected cells are not functioning, and aldosterone is always there. Aldosterone will do everything to reabsorb the sodium. So in distal tubular acidosis, aldosterone cannot remove the H plus ion. So it will remove all potassium ions in exchange for the sodium reabsorption. So that is the reason, normally 50% of the potassium is excreted and 50% of H plus is excreted for the 100% reabsorption of your sodium. But in distal RTA, you have the 0% excretion of the H plus ions. So all the sodium will be reabsorbed in exchange for the potassium. So 100% potassium is secreted and the 100% sodium is reabsorbed. Get it? This is the reason your serum sodium will decrease. Did you guys understand that? Get it? Or should I explain it? Get it? Yes. So what happens? I told you, suppose this is my principal cell. This is my principal cell. I'm going to make it very simple for you guys. And this is my blood. And this is my urine. So when the urine reaches to the principal cell, this is my principal cell. So there's a 100% sodium being there. 100% sodium being there. 100% sodium is there. So at the level of principal cell, 50% of sodium is reabsorbed. Okay, 50% of sodium is going into the blood. Is it? So here 50% is going. So this will be 50% sodium. So when 50% sodium is reabsorbed from the urine, you should also release 50% potassium into the urine from the cell. So this is normally happening, 50%. Now when the urine reaches to the alpha intercollected cells, this is my alpha intercollected cell. Alpha intercollected cell. Here I have the 50% sodium still present in the urine. 50% sodium is still present in the urine, 50%. Now I have to reabsorb this. I have to reabsorb the old sodium before it goes into the ureter. So here 50% more will be reabsorbed, and that 50% more which is reabsorbed, it will be exchanged with what? Normal. I'm talking about normal. 50% sodium goes here. So you lose 50% H plus ion in exchange for the sodium reabsorption. This is what is normally happening. So 50% potassium is excreted, 50% sodium, 50% H plus is excreted for the reabsorption of your sodium. Okay, this is normally happening. Now what happens in the distal RTA? In the distal RTA, the alpha intercollected cells are not functioning. If alpha intercollected cells are not functioning, so what will you do? What will the aldosterone do? Aldosterone will reabsorb 100% of the sodium at the principal cell. So it will do what? It's going to do what? It's going to reabsorb all the sodium at the principal cell. So you get 100% reabsorption of the sodium at the principal cell. So if you get 100% reabsorption of sodium at the principal cell, what will happen? You will lose the 100% of the potassium. And when you lose the 100% of the potassium, what will happen to the serum potassium? Your serum potassium will decrease. Simple as that. Did you guys understand it now? Very simple.
Yes.
It's very simple. So this is the reason your serum potassium is going to be decreased. All right. All right. Now this was all about your distal one. Now let's discuss the proximal RTA. So proximal renal tubular acidosis. Proximal renal tubular acidosis. This is also called as what? RTA type 2. Now,
Sir, I have a question. Quick question. The pH, so the urine pH, if it's greater than 5.5, anything greater than that would be basic, right?
exactly. Yeah.
In the urine.
Yeah. Exactly. Anything less than 5 will be called acidic. Okay. Normal is actually 5 to 5.5. Greater than 5.5 we consider as acid basic. Less than 5 or less than 4.5 it's actually considered as acidic. Okay.
Thank you.
No problem, anytime. Okay, so renal tubular acidosis type 2. So renal tubular acidosis type 2, here you get the defect in the PCT cell. You get the generalized defect in the PCT cell. PCT cells are not functioning. So if you have the defect in the PCT cells, what will happen? You cannot reabsorb bicarbonate, is it? So there's decreased bicarb reabsorption. And when you have the decreased bicarb reabsorption, what will happen? You get what? Acidosis. You get metabolic acidosis. Is it? Metabolic acidosis. Now here you are getting not only bicarb reabsorption is affected, but there can here you can also get glucose urea, phosphate urea, because a lot of the material is reabsorbed at the PCD cell. But here we are only talking about the acidosis, so better is to focus on the bicarb ions. Better is to focus on the bicarb ions. Now, what is going to happen? So, what are the causes of this? What are the causes of proximal RTA? What are the causes of proximal RTA? Proximal RTA can be caused by what? What are the diseases?
Fanconi,
What are the diseases? Very good.
Fanconi syndrome.
Very good. Myeloma, excellent. Multiple myeloma, very good. And Fanconi syndrome, excellent. You were right. Fanconi, which is actually generalized.
Acetazolamide.
Carbonic anhydrase, acetazolamine, very good. Acetazolamine, carbonic anhydrase. Carbonic anhydrase, acetazolamine, very good. Good job. Carbonic anhydrase, which will actually inhibit or you get the deficiency of carbonic anhydrase enzyme, which is responsible for the bicarb reabsorption. Okay, so how the patient is going to present? What were the symptoms of the patient?
Sir, the first one is multiple myeloma. You said, how is it causing that?
Yeah, multiple myeloma is going to do what? It's going to produce the light chains, Benz-Jones protein. Have you heard the name of Benz-Jones proteins? These Benz-Jones proteins are going to block the tubules. They are very big size. Their size is very big. So when they pass through the filtered, they are going to block your PCT cells. Once they block the PCT cells will get what? Compressive necrosis. Got it?
Is,
Very large.
are they antibodies, right?
Yeah, I mean, they are antibodies, but they are the components of antibodies. That's called your light chains. Because antibody is composed of the heavy chain and the light chains. In the multiple myeloma, you get what? More excretion of the light chains. Why the light chains come out? Why not heavy chains come out? Because glomerular size is very small. Light chains can pass it, but heavy chains cannot pass it. So when the light chains come down into the tubular lumen is very small. They cannot pass through the tubular lumen, so they will block the PCT cells. Correct?
Thank you.
Okay. So what will be the symptoms? These patients are going to have what? Hypophosphatemia, because you cannot reabsorb the phosphate as well. So if you cannot reabsorb the phosphate, you will get what? Hypophosphatemic rickets. Rickets is going to be seen in the babies because it's a congenital disorder. So you might get what? Rickets in the babies. Okay. Now, what is going to happen to the urine pH? It is interesting here. If you guys use the mind, you can tell me what will happen to the urine pH. So my urine pH will be what? Acidic or basic?
Basic.
It will be what?
Best.
Basic.
Depending upon the bicarb level. Okay. It depends upon the bicarb level. So you have the more bicarb at the level of PCT cell in the urine. In the urine, you have the bicarb, more bicarb in urine at PCT cell. I don't know what happened. I don't know. Who did it? Who did it? Who disconnected me? Who disconnected me? Okay. I don't know why I get disconnected. Maybe my internet. Okay. So we were discussing the proximal RTA, and I was asking a question, what will happen to urine pH? So you guys are telling me that is actually basic or acidic? Urine pH will be what? Everybody says basic, and I'm going to say it is acidic. Can anybody challenge me? So very good job. So depending upon your bicarbonate level in the urine. Now, if your bicarbonate level, suppose in the bicarb is high in the urine at PCT cell, at PCT cell, at PCT cell, the bicarb is very high. But as the urine passes, it goes down to your collecting ducts. So when it reaches to the collecting ducts, at the collecting duct, suppose at the collecting ducts, I have the bicarbonate of, there are only 20 molecules of bicarb. 20 molecules of bicarb is there. 20 molecules of bicarb is actually in the urine when it reaches to the collecting ducts. Now your collecting duct have the ability, I'm giving you the just example for the sake of explanation. So when the urine reaches to the collecting duct, it has what? Bicarb of 20 molecules of bicarb. Now this collecting duct have the ability to secrete 50 molecules of the H plus ions, 50 molecules, H plus ions, 50 molecules of H plus ions. Okay, it will actually secrete the 50 molecules of H plus ions. Now, these 50 molecules of H plus ions are secreted by alpha intercollected cells. Okay, if it is secreting the 50 molecules, what is going to happen? It will neutralize the 20 bicarb. It will neutralize the 20 bicarb, and still 30 molecules of the H plus are in the excess. So if your 30 molecules of H plus are in the excess, what will happen to your urine pH? It will be what? Less than 5.5 or greater than 5.5?
Less than 5.5.
Acidic.
Will be less than 4.5 or less than 5.5, it will be acidic, depending upon the bicarb level concentration. Now, there's one other scenario where you get more bicarbonate in the urine. Suppose if your bicarbonate in the urine goes to 80 molecules, you get 80 molecules of bicarb in the urine. And here at the collecting duct, you also have the 80 molecules, 80 molecules of bicarb. But the maximum capacity of the collecting duct is what? It will only secrete 50 molecules. So if it secretes the 50 molecules of H plus, 50 molecules will actually neutralize your bicarb, but still there will be excess of bicarb. That will be 30 molecules of bicarb being present, which are in the excess. So in that scenario, in that situation, your urine pH is going to be greater than 5.5. Okay. So that was actually the point which I would love to clear. Did you guys understand now? So depending upon the bicarb concentration in the urine, it can,
Yes.
okay, it's very simple. And now what will happen to my serum potassium? It will increase or decrease?
Decreases.
Why? Yes, you're right. Serum potassium is going to be decreased. You're right. Right.
Because defect in the PCT.
Because it's a stimulus for aldosterone. You know, aldo should be very high in this situation. Why aldo should be very high in this situation? Because I want to neutralize my pH of the urine. And the only way to neutralize the pH of the urine, I will increase the aldo. Is it? So aldo will do what? It will secrete more H plus into the urine, which is required in this situation. Okay. So your potassium will be low because of high aldosterone being there. Okay. And the last type of the, I would say, the renal tubular acidosis is actually called your hyperkalemic tubular acidosis. So this is called your tubular acid. This is called RTA type 4. RTA type 4. And this is the only RTA where you are going to get hyperkalemia. And I'm going to tell you why you get hyperkalemia. So renal tubular acidosis type 4. Type 4. Type 4, which is also called hyperkalemic tubular acidosis. So why I'm getting hyperkalemia? So what's the pathophysiology in the RTA type 4? In the RTA type 4, you have what? What are the causes of RTA type 4? Simply, RTA type 4 can be due to reduced aldosterone. When you get reduced aldosterone, or you have the aldosterone receptor mutation. You get what? Aldosterone resistance. Aldosterone resistance. When you have the aldosterone being low or aldosterone resistance being there, what will happen? You know what is going to happen? First, I will discuss the what is going to be the consequences, but what are the causes of this? What are the causes of decreased aldosterone or aldosterone resistance? Can anybody tell me the causes, which is called RTA type 4? It's very simple. What are the causes of decreased aldosterone? It could be
Addison disease.
ACE inhibitors, ARB.
Addison disease. Excellent. Very good. What else?
ACE inhibitors.
ACE inhibitors. Very good. ARBs. AR
ARBs.
inhibitors. Very good. What else? Diabetes. Diabetes will likely lead to neuropathy. Beta blocker.
Diuretics, spironolactone.
Spironolactone, excellent. Potassium wasting diuretic, spironolactone, TMP, SMX, and your amiloride. Amilorides could be there, and triametrione could be there, which blocks your aldosterone receptor. And if I block the aldosterone receptor, it means I'm not reabsorbing the sodium. So how I'm going to present? what will be my presentation here? So what is going to happen to my potassium?
Hyperkalemia.
Hyperkalemia. Very good. I get increased potassium. And why I'm getting acidosis here? And what's the reason I'm getting acidosis here? Yep, because I cannot secrete the H plus. I'm H plus. Is that I'm getting the H plus? Is it? I'm getting the H plus. Okay, now interesting is coming. So hyperkalemia is there. Now what is going to happen to the urine pH here?
Could you please elaborate why diabetes is causing this as well?
Diabetes. This question will be answered by the students. Okay, who wants to answer this? Yep. If
In
you
diabetic patient, decreased production of renal.
why? That's what the student. Mhm. Big
Glucose is toxic for
As insulin.
No, I'm going to discuss it. So, what happens in the diabetes? Normally how the renin is actually produced normally. Renin is produced when you stimulate the JG cells, juxtaglomerular cells. Is it? When you stimulate the JG cells. And who stimulate the JG cells? It is actually your sympathetic nervous system, sympathetics. Do you know beta 1 receptors are, this is my JG cell support. Okay, this is my JG cell, and that's your good question. I appreciate that question. Okay, so this is your JG cells, and JG cells contain beta 1 receptors. Beta 1. These are my beta 1 receptors. And these beta 1 receptors are stimulated by sympathetic nervous system, which is autonomic nervous system. And do you know this autonomic nervous system will release what? They will release the epinephrine, which will actually stimulate the beta 1 receptors. Okay, beta 1 receptors. So AP will be there. AP is there. And what will the AP do? AP will actually release. So when it stimulates the beta 1 receptors, beta 1 receptors will actually do what? It will release the renin. Now, what happens in the diabetes? I already discussed with you in the endocrine. I don't know you were with me or in the endocrine or not. Okay. So in endocrine, you get what? Autonomic dysfunction. You get the destruction. You get the destruction. You get the destruction of your autonomic nervous system. You get destruction of these sympathetic nerve fibers. And when you get destruction of these sympathetic nerve fibers, what will happen to the beta 1 stimulation? The beta 1 stimulation will decrease. And if you decrease the beta 1 stimulation, it will decrease the renal release. So this is called diabetic hyporenism. Diabetic hyporenism because your renal is actually decreased. Did you understand it now?
Yeah, much better. Thank you so much.
No problem.
Yes.
Very easy. Okay, so what's going to happen? Your urine pH. So my urine pH will be what here? It will be acidic or basic? It will be less
Acidic.
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 Acidic will be less than 5.5. Okay. All right. So these were all about your RTAs, and we complete the physiology. And hopefully tomorrow. I'm sorry if I spend more time here because this is actually high yield one, and okay, we actually spend uh, more time because pathology is not that much difficult. Physiology is actually there, which actually where I have to actually build a foundation. Okay, so in the pathology, you want me to, okay, so you want our pace to be high in the pathology? Oh, this pace is same. This pace is good. Uh-huh.
We want the same piece.
Okay, so we will try our best to actually do the pathologies. Tomorrow we do a pathology. Okay, and we will actually have the one long session and try to complete it. Okay, one long session. I will let you know, not tomorrow, but any day I will decide and we will do it. Okay, and today we also do a long session, is it? All right. Okay, any question, any confusion anybody have?
Sir, I have a quick question, sir.
Yes, please.
Sir, in RTA type 4, why pH urine is less than 5.5? I mean, it is acidic.
That will be answered by one student who said is acidic. Yes, who's going to answer it? Who's going to answer it? Okay.
I can answer this one because there's increase in H positive secretion that's causing to acidosis, like the low pH in the urine.
Mhm. So what happens, Archana, here you have the decreased excretion of ammonia in the urine.
Ammonia. Okay, sir.
Ammonia in the
Yeah.
urine. So you get ammonia, and I will explain it you to tomorrow because I'm getting late little bit. Okay. So will if you don't understand it, please let me know, and I will actually clear it to you. Okay. Sorry, I'm getting a little bit late. Okay. Thank you for
Yeah,
coming,
okay, sir. Thank
and
you, sir.
I'll see you guys tomorrow. Bye bye. Take care.